Welcome to the Inside the Boards Study Smarter series, dedicated to helping you learn to think like a question writer so you can study smarter, not harder, and succeed on your exam.
All right, we are back. I am Patrick Beeman, your host. This is the Study Smarter mini-series for the USMLE Step 2/Shelf exams. We're covering internal medicine. Today, we're back with Matthew Eisenstat from MedSchoolTutors. For all your one-to-one virtual tutoring needs, especially during your dedicated prep time, go to MedSchoolTutors.com. As well, check out our main show. The full title is Inside the Boards for the USMLE Comlex and Medical School. We've run an audio blog series featuring some question dissections and encouragement and wellness articles from the best blog in the medical education space at MedSchoolTutors.com.
A 67-year-old female presents to the emergency department, sees Dr. Eisenstat with a chief complaint of retrosternal chest pain. I'm sure this is like your bread and butter.
It's too much.
It's
way too much.
The pain came on suddenly, approximately 2 hours prior to arrival. Review of systems is also positive for nausea and diaphoresis. Vital signs show hypotension. On physical examination, she has jugular venous dissection, and auscultation of the heart reveals a pansystolic murmur heard best at the lower left sternal border. EKG shows ST segment elevation in the right precordial leads. Which of the following is the most likely diagnosis? Do we have A, a dissecting aortic aneurysm, B, pericardial tamponade, C, pulmonary embolus, or D, a right ventricular myocardial infarction?
Love this question. Right. This person is...
You like this one?
This is my wheelhouse. So, sick person, chest pain. Love it.
And teach us everything. Teach me everything.
Go find an attending. So this is the simplest form of question. So you're just looking for a diagnosis here. So there's no tricks on this one. There is more to this question than really meets the eye, though, and I think it's worth diving a little bit into some of these answer choices. So you have a 67-year-old lady, so it's pretty fairly safe to assume she's not the perfect ideal bill of health. But they don't give you any big risk factors or anything like that. But the next couple sentences really paint the picture of somebody who's in severe distress. So, nausea, diaphoresis. I had a attending once tell me, if your patient is diaphoretic, then you should be diaphoretic too. I live by that. So that's one of those symptoms that always makes my ears perk up a little bit. She's got signs of probably some heart failure with the JVD.
Yeah.
Doesn't show, it doesn't say that she's got rails on pulmonary exam, so maybe we're not thinking as so much of a left-sided process as we would if, they were short of breath on a bunch of oxygen with rails up to their eyeballs. But then, so interesting little tidbit. Again, the murmurs are just sort of like, they're always in these questions a little thrown in. So the pansystolic murmur, best heard at the left sternal border. So going through your cardiac positioning for auscultation, thinking it's likely at the tricuspid. Left sternal border is generally a tricuspid lesion. And then a pansystolic murmur, you're suspecting tricuspid regurg. Now, it's not, that's one of those ones you're not sure what to do with. I've never, you can't just like, it's tricuspid regurg is answer C. So it's added a little bit of information, but you're not sure what to do with that yet. And then you've got these ST segment elevations in the right precordial leads. So a little bit on the right precordial lead thing. The EKG, just purely by design, is biased towards looking at the left ventricle. So all your limb leads and your standard precordial leads all directly look at the left ventricle and can sort of indirectly look at the right ventricle. But in certain pathologies, you actually want to see that what's actually happening in the right ventricle itself. So you can take a couple of the leads, V3 and V4, and flip them over the sternum to do what we call right-sided EKG leads. It's unclear from. Yeah,
I'm an OBGYN.
It's a pro move. You should break that out on your pre-C-section screenings. And you could do you could do posterior leads. You could put leads wherever you want. So what they're actually getting at is sort of hard to figure out because you're not really sure. Are they talking about like a rightward facing lead or is it a right-sided EKG? Either way, you can sort of ignore all that extra mumbo jumbo and just say, something on the right side looks like there's ST elevation. So whether it's a right-sided EKG or whether it's the rightward facing leads is what we call them, like a V1, V2. That's a little more advanced, but something's going on with the right side of the heart. The problem with all that is that a lot of these conditions will actually cause right-sided heart problems. Going through some of these. So A was dissecting aortic aneurysm. Yeah. I'm like embarrassingly enough, like 8 or 9 years, something like that, out of med school. But I would be looking for central chest pain that, radiates to the back, between the scapula, right? That's what I'd want to see for an aortic aneurysm. Especially in boards land. Exactly. So, and you can get things like, my left leg is numb because now the circulation is cut off to the left leg or something like that. But typically more of a tearing pain central. But the interesting thing about dissections is they can actually dissect back into the coronary arteries and can cause ST segment elevation. Probably not in a right-sided distribution, but it's not totally ridiculous to think a dissection on your differential for ST segment elevations. That being said, they're giving you this typical crushing chest pain with nausea, vomiting, that sort of thing. They don't give you any other symptoms of a dissection, like a super elevated blood pressure or numbness in an arm or leg or something like that. So, I could pass on that one, but it's not a ridiculous
All right,
answer.
Pericardial tamponade. I mean, to me, I'm looking for Beck's triad if I have this. So that's JVD, hypotension, and muffled heart sounds, right? We've got the dyad here.
The dyad. I hate triads. I hate triads so much. So you got, parts of it, but it's so funny. Like UWorld and NBME exams never pass up the opportunity to do like a electrical alternans or pulsus paradoxus or something like that. So they're gonna give you the classic kind of thing. So you're missing some of that extra supporting evidence to suggest a tamponade. And then you're always got to think, like, why is there a tamponade?
Shouldn't she have been in a car accident, hit her steering wheel, and have, like, I don't know. I mean, I really don't know. Got punched in the heart.
Punched in the heart.
Chief complaint.
I'm still waiting.
It'll happen. Longer you practice.
I hope so.
I'm gonna keep pericardial tamponade on the maybe. If I'm reading through this vignette, and then the next one's pulmonary embolus. Why not pulmonary embolus?
This is the boogeyman in the ED. So this is the great mimic of a lot of things. So a lot of the symptoms that they're describing, again, you're getting that classic ACS story with that substernal, retrosternal chest pain is how they described it. Usually PE is more of a pleuritic pain, more of a sharp pain, more with breathing, especially if it's big enough to have ST changes on an EKG, it's probably big enough to make you hypoxic or have some significant vital sign abnormalities. There is some hypotension, which is always a worrisome sign for regardless of whether it's an ACS or a dissection or what. Without those classic symptoms and the chances of a PE actually having ST elevations is very low. Now, I'll tell you, it can happen, but on the test, what they'll give you is either the sinus tachycardia, or they'll give you the S1Q3T3, which is, not terribly sensitive or specific, but people like to throw that around. So they're not giving you the classic signs or symptoms. They're not giving you the classic EKG findings. They're not giving you anything like hypoxia or she was bed rest or had, signs of a DVT or anything like that. So far less likely. So you can back.
All right, good. So we weren't too happy about the other ones, and we read through the vignette and we're like, oh yeah, she's going to have an MI. Answer choice D, the correct answer is a right ventricular infarction. I mean, my question is this an easy question?
No. And I think the more you think about it, the harder this question gets, which is always tough, especially when we're sitting here dissecting it. But the kicker to this is the classic ACS symptoms and the likelihood of an EKG showing right-sided ST elevations. But it's hard. There's little, the more you dig into this question, the more you can see how someone.
Yeah. And I mean, this kind of goes back to like what I said before too. I feel like if I got this question on an exam, I'd be like, what am I missing? Like, this really seems like a clear-cut case. This is a softball of a question. It's got to be myocardial infarction of some sort. And then I'd get to like the answer choice and I'd be like, what am I missing? Yeah. How do you avoid that sort of distrust, that tendency towards distrust and thinking they're trying to trick you?
Yeah, the chances of them tricking you. So there's the occasional trick question on every exam, and it always happens, but the likelihood of that happening is, I would say, less than 1%. So always go with trusting the test maker to make a more straightforward question. Don't, and especially on this one. So if you're thinking about this from a test taker's standpoint, knowing about a right ventricular infarction is important. There's a lot of reasons. So it frequently, more so missed, again, because our EKG is biased to look at the left ventricle. So the more subtle EKG findings, the less typical symptoms. The other part of this is that if you miss it, then you can give someone a medicine that will make them very sick, and that's nitroglycerin. So people who have right ventricular infarctions are what we call preload dependent. So their right heart can't pass blood to their left heart, and they're dependent on that volume that they have in their preload system. So if you bottom that out with nitroglycerin, these people get so hypotensive, and they will, go from systolics in the 90s to looking gray ashen, being altered. The systolic
from a right ventricular infarction to a pan ventricular and atrial infarction.
To perfusing absolutely nothing. And the thing is that we give nitro, so often, we give it all the time. And so from a test taker standpoint and from a clinician standpoint, you really want people to recognize this as a possibility. So it's such an important point to teach that it's not something you're going to get a
yeah. So I guess the high yield points then to remember on that would be know what a right ventricular infarction looks like, maybe give us in a second some bullets to remember on that, and then secondly, don't give the nitroglycerin as part of the Mona B regimen.
Yeah, Mona B.
So if I'm on a test at the medical student level, right ventricular infarction, what's going to kind of cinch that for me?
Right ventricular infarction is very common with elevations in what we call the inferior leads. So 2, 3, and AVF can have a right ventricular infarction. You always want to avoid nitroglycerin or anything that reduces preload because they're preload dependent. And actually, you might need to give them fluids. So can occur with inferior leads, ST elevations. Otherwise, treat like a normal ST elevation MI, but without.
So she'll get a stent, very likely. on then to our final question for this particular episode. A 52-year-old male presents to the emergency department with a 1-hour history of crushing chest pain associated with nausea. His medical history is significant for hypertension. Family history is positive for early onset heart disease. Nitroglycerin is administered, but despite this, his pain persists. EKG shows ST segment elevation in leads V2 through V4, as well as AVL. Which of the following is the most appropriate next step in the management of this patient? So is it A, digitalis, B, lidocaine, C, coronary artery bypass grafting, or D, thrombolytic therapy? I don't know. I probably would have written this question differently, specifically the answer choices to make it a little more difficult, I guess. But let's go through it. What stands out to you here is things to learn.
Sure. So this guy's probably sitting in the hallway next to the lady in question 2. So the couple things about so you got just sort of cutting to the point. You've got a guy. Older guy, so older male, already some Framingham risk factors for heart disease, and then it's the big one. So there's not a lot of
ambiguity
ambiguity as to what's happening. You've got a big, probably a anterior lateral STEMI going on. So the interesting part to this question is if you went to school in a big academic center or did saw medicine occur in a bigger center, you're sitting there thinking like, where's the cath lab? Where's the balloon and the stent? What are we doing here? So that would be the one thing that would probably throw you off if you were paying attention on your cardiology rotation. So you got a couple different answer choices. You've got 2 antiarrhythmics, a cabbage that's delayed, and then thrombolytic therapy. I think one of the biggest principles to treating these acute myocardial infarction events is the paradigm that time is tissue. So time is myocardium. So any delayed therapy is probably not going to be the right answer. So pretty immediately, you can take off cabbage off your list of answers, and then you're left with this thrombolytic therapy, which you may or may not know what that actually means, versus these antiarrhythmic drugs. So digitalis being the cardiac glycoside that increases contractility and can reduce heart rhythm problems. I'll feel fairly confident in saying that I never expect that to be an answer on a cardiology question, just because. So the one thing we all know about DIG is like, well, use it heart failure. It doesn't decrease mortality, but maybe it increases the chance that you stay out of the hospital, that sort of thing. But it's a controversial therapy, and the chances of them putting something controversial in a test are so incredibly low because you have to have a clear cut, superior.
I mean, this is what I often say is like the boards try to take the very gray world of clinical medicine and turn it into like a mathematical black and white science, and it's just not. That's not how medical practice works. So, in that instance, I feel like you have an answer choice on an exam that is controversial, or it's like one of those things that can be used everywhere. It's not like a preferential treatment or something that's used incredibly rarely or third line, especially if you're in a guessing situation. Don't even pick that.
No, I would never. So you may, they do occasionally give you the old digitalis overdose question, but I've never seen dig correctly as a correct answer for a cardiology question.
Okay,
so you could pretty much immediately cross that one off too. So that leaves us with lidocaine, which is again sort of like DIGE. It's in the realm of gray. It's a medication that's falling out of favor fairly quickly, and is quickly getting replaced by amiodarone. So as a third year student, you probably don't know that, but it's in those, whenever you're talking about like quinidine or propafenone or procainamide or all those different, especially the class 1 antiarrhythmics, there's so few instances where I would use that either in real life or on a test question that unless we're talking about like maybe a Wolff-Parkinson White, maybe a tachydysrhythmia from a Wolff-Parkinson White where you want to avoid calcium channel blockers and beta blockers. That might be a time where 1A antiarrhythmic medicine might be used. But the question has nothing about his rhythm. We just know that he has ST elevation. So yeah, no, that's a no from me.
No to lidocaine, no to digitalis, no to cabbage. That leaves us with thrombolytic therapy.
Thrombolytics.
So this is one, whenever I see that, or like in the context of either the heart or the brain, I'm always like, isn't there some timeline I'm supposed to remember? Like, that's the big thing for me.
Yeah, and they don't test that much.
Why do we worry about it so much then?
It really comes up in real life a lot, but not. The boards, I feel like stay away from that. Sort of digging into the answer a little bit. So when you're talking about an acute ST elevation MI, you want to open up the occluded vessel, and there's a couple different ways of doing that. There's PCI, which is percutaneous coronary intervention, which is a catheter where you put a balloon in, you blow it up, and then you put a stent over it. Which is the preferred therapy. If you have it, you should go for PCI.
On this question, if that had been one of the competing answer choices, hands down, you should pick that one over. With, of course, everything else being the same, and she didn't have a contraindication to a procedure and blah, blah, blah.
Yeah. Hands down would be a better therapy. It has less contraindications. It's safer. In some studies, outcomes are better. It's a pretty clear-cut, superior answer, and that's why everyone's trying to get their cath lab up and running. You're sort of left with like, well, when am I using thrombolytics? So thrombolytics is clot-busting drug. TPA would be the other name for it. In the situation that we're describing in ST elevation MI, you're doing it in situations where you don't have a PCI available. So you don't have a cardiologist who can do a catheter and stent procedure. And then you can't get them there within 90 minutes from first contact to the time that they do the stent. So that timeline itself is very institutionalized. So that is something that I don't think the boards would touch.
Okay.
But if you were given thrombolytics, you were given this exact scenario, you had both available, I would pick percutaneous coronary intervention. Got it.
So basically this answer is correct because PCI is not one of the answer choices.
Yeah, exactly.
Which, it's kind of funny, but like that's how you have to think on the boards. Like that's another way to test your understanding of, say, second line drugs or therapies, or to assess whether X therapy is a treatment for Y disease, when maybe that disease has like 15 different options for treatment. It's just don't include some of them as answer choices.
It's one of those. It's not a trick. It's a test writing strategy.
Yep.
But that's how they get you on the second line indications.
All right. Anything else about this question? High yield points to remember.
No, just remember ST elevation MI needs an immediate therapy, reperfusion of that vessel, PCI if you have it. Cabbage is an interesting option, but the delay is what makes me not think that that's the correct answer. There are certain instances where a cabbage is necessary if there's a bunch of complex coronary lesions or something like that. But that's an advanced topic. That's like the cardiologist, while he's doing the catheter, makes that decision. So that's not something I would expect
a medical student
to have, a medical student to know.
Yeah, I think all I can remember from that is that there was a controversy between 2006 and 10 about using cabbage for multi-vessel coronary artery disease. I'm sure that's probably still the case because...
Yeah. And I think it's gotten more controversial and not less controversial. So.
Which means more confusing.
More confusing, but less likely to be on a test question, I think.
Hey, I mean, that works out for those who are listening. So
glass half full.
Yep. All right, man. Well, thank you for your time. If people want to get in contact with you and have you walk them through their emergency test preparation, or find a mentor who will walk them through on a more casual and consistent basis, they can go to MedSchoolTutors.com. Thanks for your time and enjoy the last moments of residency on your way to the Toxicology Fellowship.
Will do. Thanks, Patrick, for having me.
Yeah. The music for today's podcast is by DJ Bezo. The track is King Jeff and his apprentice Bart. Elizabeth listened to this and said, after I mentioned that he happens to be my son, that I should also mention that he's only 12 years old. So if you are so inclined, head over to SoundCloud and follow DJ Bezo. That's Beezo. You will certainly make a 12-year-old kid's day, and I would certainly appreciate it. As always, thanks for listening.